Now we'll be covering the second part of viral hemorrhagic fever from Apurba Sastry Essentials of Microbiology. In this, we'll be covering chikungunya, Carnosaur forest disease, and some other viral hemorrhagic fevers. So, starting with chikungunya. Chikungunya fever is a re-emerging disease characterized by acute fever with severe arthralgia. It belongs to family Togaviridae of genus Alpha virus. Now, it is the enveloped virus containing single stranded RNA. History. The name is derived from Mancote word kunguela, meaning that which bends up or gets folded, in reference to the stooped posture which develops as a result of the severe joint pain that occurs during the course of illness. Transmission. Human transmission occurs by Aedes mosquito, primary Aedes aegypti, which bites during daytime, rarely by vertical transmission from mother to fetus or by blood transfusion or organ transplantation. Transmission cycle. Chikungunya virus is maintained in the environment through urban cycle between human and Aedes aegypti and sylvan or jungle cycle between monkeys and forest species of Aedes. Now, clinical manifestations. Intubation period is about 5 days, 3 to 7 days. Acute stage, most common symptoms are fever and severe joint pain due to arthritis, worsened at morning. Arthritis is polyarticular, migratory, and edematous, joint swelling, predominantly affecting the small joints of wrist and ankles. Other symptoms include headache, muscle pain, tendinovitis, or morbilliform skin rashes. Symptoms are often confusing with that of dengue. In general, chikungunya is less severe, less acute, and hemorrhagic manifestations are rare as compared to dengue. As we can see in this table, the fever is acute 2 to 4 days in chikungunya, while 5 to 7 days gradual in dengue. Polyarthritis is frequent, may last longer, more than 1 month in chikungunya, whereas less common or of short duration in dengue. Tensinovitis is common in chikungunya, which is not in dengue. Rashes appear on day 1 to 4, maculopapular in chikungunya, 3 to 7, petechic or maculopapular in dengue. Myalgia possible in chikungunya, common in dengue. Leukopenia common in chikungunya, infrequent in dengue. Thrombocytopenia infrequent in chikungunya, common in dengue. Retroorbital pain rare in chikungunya, common in dengue. Hypertension and shock possible in chikungunya, common in dengue. Minor bleeding rare in chikungunya, common in dengue, and hematocrit normal in chikungunya while increased in dengue. Now, the chick sign. Yeah, after arthritis, we see the chick sign, also called brownie nose appearance. Rare presentation characterized by hyperpigmentation over centrofacial area occurs due to increased intraepidermal melanin retention triggered by chikungunya virus. Most patients recover within a week, except for joint pain last for months. Chronic stage, 10 to 15%. Most patients recover within a week, except for the joint pain last for months, rarely up to 1 year. Now, high risk group. This group includes newborn, older adults more than 65 years, and person with underlying hypertension, diabetes, or heart disease. Epidemiology. Chikungunya virus was first reported in Africa, Tanzania in 1952, was subsequently introduced into Asia and had caused several outbreaks in various African and Southwest Asian countries. Bangkok and India. India past several outbreaks were reported during 1963 to 73. Example Kolkata in 1963 and South India in 1964. Puducherry, Chennai, Vellore region and Barasi in Maharashtra in 1973. Since then, it was clinically quiescent and no outbreaks were reported between 1973 to 2005 from most parts of the world except for few sporadic cases which occurred in various places of the world including India, Maharashtra. Re-emergence. Reunion outbreak in 2005. Chikungunya re-emerged in Reunion Island of Indian Ocean and affected 2,58,000 people, almost one third of country's population. Now, reasons for re-emergence. Re-emergence in 2005 was believed to be a novel mutation in the virus and a change in the vector. New mutation E1A226V. Chikungunya virus underwent important mutation. Alanine in the 226 position of even glycoprotein gene is replaced by valine. Newer vector, Aedes albopicus mutation led to a shift of vector preference. Mutated viruses were found to be 100 times more infective to Aedes albopicus than to Aedes aegypti. Spread. Following the reemergence, it has been associated with several outbreaks in India, other Southeast Asian countries, and African countries, and has also spread in some areas of America and Europe. The most recent epidemic that occurred in Colombia during 2014-15, which witnessed 82,977 clinically confirmed cases by the end of 2014. India at present, chikungunya is endemic in several states like Karnataka, Tamil Nadu, Andhra Pradesh, West Bengal have reported high number of cases. In 2021, nearly 8,806 confirmed cases were reported from India. Maximum number of confirmed cases were reported from Gujarat, Maharashtra, and Karnataka. Now, lab diagnosis. Laboratory diagnosis of chikungunya is similar to that of other arbovirus or as described before. Virus isolation in mosquito cell lines takes 1 to 2 weeks, is useful in early diagnosis 0 to 7 days but available only in reference centers. Serum antibody detection. IgM appears after 5 days of infection and lasts for 3 months. IgG appears late after 2 weeks and lasts for years. So detection of IgM or a fourfold rise in IgG titer is more significant. MAC. IgM antibody capture ELISA using virus lysate is the best format available, showing excellent cross react sensitivity 95% and specificity 98% with only little cross reactivity with other alpha virus and dengue. In India, MAC ELISA kits are supplied by National Institute of Virology, Pune. Several other rapid tests, example ICT using envelope antigens, are also available. Molecular method reverse transcriptase PCR has been developed to detect specific gene, example NSP1, NSP4 in blood. Hematological finding such as leukopenia with lymphocyte predominance, thrombocytopenia rare, elevated ESR and C reactive protein. Treatment of chikungunya is only supportive measures. No specific antiviral drug or vaccine are available. The vaccine is not available although trials are going on. Okay, so now we come to Carnosaur forest disease. Carnosaur forest disease was first identified in 1957 from monkeys from the Carnosaur forest in Shimoga district of Karnataka, India. It belongs to family Flaviviridae. It is an enveloped virus containing ssRNA. Epidemiology. Heart ticks, Hemophilus spignegra are the vectors of KFD virus. Host monkeys, rodents, and squirrels are common hosts which maintain the virus through animal tick cycles. Monkeys are the amplified host where the virus multiplies exponentially. Seasonality. KFD is increasingly reported in dry months November to June, which coincides with human activity in the forest. Situation in India. KFD is currently endemic in 5 districts of Karnataka, Shimoga, North Kannada, South Kannada, Chikmagaluru, and Udupi. Largest outbreak had occurred in 1983-84, which has witnessed 2167 cases with 69 deaths. Currently, only focal cases occur at the rate of 100 to 500 cases per year. There is a declining trend of incidence after the initiation of vaccine in 1999, except for the outbreak that occurred in 2013, which witnessed 215 suspects with 61 confirmed cases. Clinical manifestation in humans. Incubation period varies from 3 to 8 days. First stage hemorrhagic fever. It starts as acute high fever with malaise and frontal headaches, followed by hemorrhagic symptoms such as bleeding from the nasal cavity and throat and gums, as well as gastrointestinal bleeding. Second stage, in the form of meningoencephalitis, may occur at 7 to 21 days after the first stage. Lab diagnosis. Diagnosis is made by virus isolation from blood or by IgM antibody detection by ELISA. Recently, nested RT-PCR and real-time RT-PCR have been developed detecting viral RNA NS5 non-coding region in serum samples and can provide early, rapid, and accurate diagnosis of the infection. Non-specific findings such as leukopenia, thrombocytopenia, and decreased hematocrit, albuminuria, and abnormal CSF are found in second stage. Treatment. Treatment of KFD is only by supportive measures. No specific antiretroviral drugs are available. Killed KFD vaccine. A formalin inactivated chick embryo vaccine has been developed for KFD in Hafkin Institute, Mumbai. Schedule 2 doses of interval of 2 months, followed by a booster dose at 6 to 9 months, then after every 5 years. Target area. KFD vaccine is recommended in endemic areas of Karnataka villages within 5 kilometers of endemic foci. With that said, let's start with other viral hemorrhagic fevers. Viral hemorrhagic fever can also be caused by filoviruses, example Ebola and Marburg virus, and rodent-borne viruses such as hantavirus and arenavirus. Filovirus infections. Family Filoviridae contains two antigenically distinct genera, Ebola virus and Marburg virus. Both cause African hemorrhagic fever. A third genus has recently been described, virus. Morphology. They are pleomorphic, mostly appear as long filamentous threads ranging from 80 to 1000 nanometer, the average size being 665 nanometer Marburg to 805 nanometer Ebola. Highly fatal. The great matter of concern is that all of the viral hemorrhagic fever, Marburg and Ebola virus have the highest mortality rates, 20 to 90%. Ebola virus disease. Ebola has become a global threat because of its explosive outbreak in 2014, which was declared by WHO as a public health emergency of international concern. History. Ebola virus disease in humans appeared for the first time in 1976 in two simultaneous African outbreaks occurring in Sudan and Democratic Republic of Congo. The latter outbreak occurred in a village near the Ebola River from which the virus takes its name. Species. Ebola virus has six stable subtypes or species: Zare, Pundiboago, Sudan, Thai Forest, Reston, and Bombali. All differ from each other up to by 40% of the nucleotide sequence. Species of epidemiological importance are Ebola, Sudan, Thai Forest, and Bundibuago. Viruses can cause disease in humans, but the Reston virus causes disease in non-human primates but not in people. Pombali virus were recently identified in bats. The virus that had caused an explosive outbreak in Democratic Republic of Congo and 2014 Western African outbreak belongs to Zari species. Geographical distribution. Since the discovery, Ebola virus has caused several outbreaks in various African countries. DRC outbreak. Democratic Republic of Congo continues to report Ebola outbreaks in recent years. 11 outbreaks reported so far, the most recent being in June 2020. India. There is no confirmed case documented yet. West African epidemic 2014 to 16. The largest outbreak occurred in 2014 to 16, reported 28,616 cases with 11,310 deaths, 40% mortality. Three primary countries affected were Guinea, Liberia, and Sierra Leone. However, few cases have also been reported from several other countries. Reservoir. The reservoir host for Ebola virus are unknown but are suspected to be infected animals such as fruit bat or primates, apes, and monkeys. Transmission. For every outbreak, Ebola virus is introduced into human population through close contact with the blood, secretions, organs, or other body fluids of infected animals such as chimpanzee, gorilla, fruit bat, or monkeys. Human to human transmission. Once introduced into humans, Ebola virus spreads among people via direct contact through broken skin or mucous membranes of eyes, nose, or mouth, with blood secretion, organs, or other body fluids of infected people, infected surfaces and materials, example bedding, clothing, syringe, etc. Healthcare workers and close contacts, family members of infected individuals are at greater risk for contracting the infection. Ebola virus can stay in semen for up to 3 months, although sexual transmission has not been reported yet. Clinical manifestations. Incubation period is about 2 to 12 days. Common symptoms include fever, headache, muscle pain, sore throat, followed by abdominal pain, vomiting, and severe watery diarrhea, diffuse erythematous maculopapular rash, fatigue, ecchymosis, bruising, often leading to shock and death. Mortality. The average case fatality rate is about 50%, vary from 25 to 90% between outbreaks. Lab diagnosis. Serum antibody detection. ELISA detects both IgM and IgG separately by using recombinant nucleoprotein and glycoprotein or GP antigens. IgM appears after 7 days of symptoms and lasts for 3 to 6 months. IgG appears after 2 weeks and persists for 3 to 5 years or more. Now, other antibody detection assays include immunofluorescence test and antibody phage indicator assay. Serum antigen is detected by capture ELISA. The target proteins are NP, VP40, and GP. Immunohistochemical staining and histopathology can also be used to localize Ebola viral antigen in the tissue. Molecular methods such as RT-PCR and real-time RT-PCR assays are useful to detect specific RNA such as NP and GP gene. Virus is detectable after 3 days of onset of fever and remains positive for 2 to 3 weeks. Electron microscopy of the specimen shows typical filamentous virus as we can see in the figure here. Filamentous shaped virus in electron micrograph. Virus isolation in virocell line. Processing the specimen should be carried out in a biosafety level 4 cabinet as there is a great risk of laboratory spread of the virus. Treatment. Supportive care such as rehydration and symptomatic treatment improve survival. No proven treatment or vaccine is available yet. Prevention. People who may be exposed to patients suspected with Ebola should follow the following steps. Practice proper infection control and sterilization measures such as strict hand hygiene and personal protective equipment PPE such as overall and N95 mask. Isolate patient with Ebola from other patients. Avoid direct or indirect contact, cloth, bedding, needle, etc. with or body fluids or blood or other secretion of suspected Ebola cases. Avoid attending funeral or wear PPE while attending funeral. If traveling to Ebola outbreak area should be monitored for 21 days after returning. Vaccine. No Ebola vaccine is approved for human use yet. However, several vaccine trials are going on. Strive trial. Sierra Leone trial to introduce a vaccine against Ebola. The vaccine candidate used here is RVSV-ZEBOV, which is recombinant vesicular stomatitis virus Zaire Ebola virus vaccine. This vaccine is being used in the ongoing 2018-29 outbreak in the DRC. Marburg virus disease. Marburg virus disease was first reported in Germany and Yugoslavia in 1967 among lab workers exposed to tissues of African green monkeys imported from Africa. Since then, over 450 cases have been reported in various African countries such as Kenya, South Africa, Democratic Republic of Congo, Uganda, and Angola. In the most recent outbreak was in Angola 2005 affecting 252 people with 227 deaths with mortality of 90%. Now the last topic of the chapter is rodent-borne virus infections. Rodent-borne virus or robovirus are transmitted from rodents to man by contact with infected body fluids or excretions. They are maintained in nature by transmission from rodent to rodent without participation of arthropod vectors. Major rodent-borne virus include hantavirus and arenavirus. Hantavirus disease. Genus Hantavirus belongs to family Buenaviridae. Morphology. They are spherical enveloped virus containing triple segmented negative sense ssRNA. Clinical manifestation. They use two categories of clinical manifestations. Hemorrhagic fever with renal syndrome HFRS. It is caused by several members of hantavirus such as Hantan virus, Dobra virus, Pumula virus, and Seoul virus. Hanatavirus pulmonary syndrome HPS is caused by another member Sin nombre virus. Epidemiology. Worldwide, about 1 to 2 lakh cases of hantavirus infections occur annually. HFRS. Due to Hantan and Dobra virus occur in Asia, particularly in China, Russia, and Korea. Pumila virus causes a mild form of nephritis called nephrophthia epidemica, prevalent in Scandinavia. Sin nombre virus causing HPS is prevalent in America. Diagnosis is made by detection of viral RNA by RT-PCR. Treatment. There is no specific antiretroviral therapy for hantaviral disease, or only supportive symptomatic treatment is given. Arenavirus infection. Arenavirus are pleomorphic 550 to 300 nanometer in size, enveloped with large club-shaped pepelomeres and contain segmented ssRNA 2 segments. Based on geographical distribution, they are grouped into New World virus and Old World virus. New World virus include Junin, Machupo, Guanarito, and Sabia virus. They cause South American hemorrhagic fever. Old World virus example include Lassa virus cause hemorrhagic fever in Africa. Lymphocytic choriomeningitis, LCM virus, they primarily infect mouse, rarely cause meningitis in humans. Now coming to the expected questions. First question, Sunita, a 29-year-old female, came to casualty with complaints of high-grade fever, severe joint pain, back pain and myalgia. Gradually she developed petechial rashes over the body. On examination she was found to have jaundice, hepatomegaly and low platelet count 30,000 cmm. A tourniquet test done over the cubital fossa demonstrated 25 petechial spots per square inch area. On inquiry, she told that she has been bitten by mosquitoes. So clearly, this is a case study of dengue. Now it asks what is the clinical diagnosis. We can write what are the typical clinical presentation and pathogenesis. We can write, and how will you confirm the diagnosis. Obviously, it can be done. Now the short notes on chikungunya, Canisopharus disease, and Ebola virus disease. All you can write now. Now the first MCQ, Canisopharus forest disease is transmitted by, its answer is tick. In dengue infection, earliest detectable number of petechial response per square inch in cubital fossa should be more than 20. Antibody dependent enhancement ADE is observed with dengue hemorrhagic fever. Okay, so this completes your viral hemorrhagic fever chapter. Next, we will be continuing with malaria and babesiosis. Okay, like, share, subscribe. Thanks for watching.